Hello, everyone. Thank you for watching my presentation and the importance of cultural competency within the healthcare realm. I want to first introduce the diversity of the United States and the importance of understanding the growing ethnic infusion and revolution that we have experienced in our country over several years now. Since the year of 2000, we have seen an increase in ethnic diversity throughout the country. However, this index exemplifies that cultural and ethnic infusion within our country. The blue areas are ethnically diverse areas that have remained ethnically diverse, while the yellow areas and the whiter areas are high and low diversity but are experiencing big increases in ethnic diversity. One of the important notes of this index here is that the Washington Post has indicated that an estimated 160 million people live within these blue areas, and that constitutes about 60% of the nation's population. This exemplifies and highlights the importance of cultural competency within our healthcare providers, as so many of our nation's citizens live within these highly ethnically diverse areas. It's difficult to pinpoint a definition for patient advocacy and for cultural competency. However, I elected to choose this definition of communicating with and informing patients, protecting patients, speaking out for patients, and building relationships with patients. The reason I chose this definition of patient advocacy is because it's multifaceted, it's multi-layered in the sense that the providers, or in this case, Ronbaum and Schmer, were using nurses as their providers. They are communicating with the patients and developing a relationship individually with them. However, they're also empowering and educating these patients so that when they step out away from that individual provider, they can speak for themselves and be competent in within their health and their decision making of their health. For cultural competency, I want to introduce three models of cultural competency to create a broader comprehension or a broader view of cultural competency. The first is the Bennett model. In this model, Bennett describes his view of cultural competency as a spectrum, with the lowest or one end of the spectrum being denial and avoidance of cultural differences, and the other end or the opposite end of the spectrum to be integration. Bennett concludes that an individual who obtains integration has the ability to evaluate and acknowledge ranges of cultural and ethnic differences and ingrain their independent cultural differences and combine all of those to understand the patient's individuality and therefore apply medical care and decision making based off of that understanding. The Purnell model is slightly different. It's more on the holistic side. Purnell poses that cultural competency should start with a global outlook, and that's what that larger blue circle indicates, is an overview of global impact that of the society and other environmental factors can play into an individual's cultural or ethnic diversity. The yellow circle is then where the professional would wind up. So slowly that global circle will become smaller and smaller and smaller, and to the point where the healthcare provider can individually assess, recognize, acknowledge the individual's family, their environment, their societal factors that play into their ethnic and cultural diversity, and by understanding those complex factors of that specific individual, they can then provide the specific care for that patient. The third model is the cross model of cultural competency. This is widely used in educational platforms. And this is a step by step model, meaning that you start from the bottom in cultural destructiveness with the aim of passing from cultural destructiveness to cultural incapacity to cultural blindness, all the way up to cultural proficiency. I suspect that this model is used within the educational platform in settings due to the fact that it closely resembles the traditional educational and teaching models, such as Bloom's taxonomy, where you must achieve or demonstrate the ability to perform certain tasks, or in this case, to be able to acknowledge the cultural stage at which you're in, and then therefore move on to the next one. For the rest of our discussion and conversation, I do want to stick with the cross model, and the reason I want to stick with the cross model is because cross provides a good analysis here of knowledge, the skills, and the attitudes needed for a professional to be culturally competent. I pose that most healthcare providers within their specialty, so nurses and their education, and doctors or physician assistants within their specified education, all receive relatively similar knowledge. Secondly, they all receive similar or relatively similar skills applications and practical skill learning that would put them all on a level playing field. The difference, or at least where I believe a lot of healthcare professionals can get stuck, is in the attitudes portions and the affect or in the empathy they show to the patients. With that, I do want to lay the foundation of how cultural competency of a healthcare provider can affect the psychosocial outlook, perspective, or feeling of an individual patient by sharing with you all the self-determination theory. The self-determination theory is a motivational theory, and the reason I bring this up is as healthcare providers, we need our patients to be motivated to continue seeing us, to be motivated to continue their care away from us, meaning if I give someone a home exercise program, I need them to have a sense of intrinsic motivation to continue that care as they go home. For that reason, the self-determination theory, I believe, ingrains itself naturally within cultural competency care model with our healthcare professionals. Innately, humans want to feel autonomous, competent, and relatable or related to. So I'll slowly integrate the self-determination theory into the cultural competence discussion. However, the more we can tap into the intrinsic motivation of our patients, the more effective our care can be. We're only with the patients for a limited period of time. Therefore, if we can ingrain our desires and our hopes for the patient within their care and they carry that along with them, we then therefore become more effective. The CLAS standards are standards that were created for healthcare providers, organizations, private practices, and hospitals. And they were created to provide these institutions or these entities practical education, application examples, and a model to follow to improve health equity. Health equity is important, it's vital, it's simultaneous. You can interchangeably use it within cultural competency. And it's important to understand that the four components of the CLAS standards are the principal standard, the governance, leadership, and workforce, communication and language assistance, engagement, continuous improvement, and accountability. An example of the principal standard is as basic as it sounds. It's the golden rule: you treat others how you want to be treated, you interact with patients in an equitable manner, and you're meeting the patient at their level. This can come down to a simple use of layman's terms, providing explanations and basic terminology so the patients feel autonomous when they are speaking with others or speaking to other providers about their conditions, about their circumstance, etc. Governance, leadership, and workforce. Creating a leadership group that closely reflects the patient demographic. This is vital. as it will improve the relatedness of the patient to their providers. Oftentimes, in my experiences, if we have a provider who does not understand or comes from a similar ethnic background, it's difficult for the patients to believe that that provider truly understands some of the ethnic barriers that may be present within receiving care. Therefore, if you have a leadership group that reflects the patient demographic, you can improve the relatedness, and not only that, but uh, things such as competency and autonomy also improve as they're able to communicate with that individual a lot better. And communication is very important. It removes a barrier of our providers to become effective communicators of care and also of treatment options. Many times, those who cannot communicate well for themselves will not ask questions. Therefore, it will decrease their autonomy because they do not know what decisions and what options they may have, therefore, limiting the way they may feel about the treatment they are receiving. Engagement and continuous improvement and accountability. This is one of the things that I believe a lot of organizations fall short of. It's difficult to continuously assess and review the needs of a community. They can change so rapidly, and it's difficult fiscally for institutions to keep up with these changes. However, by assessing these needs, you are there for increasing the ability to relate with that patient demographic and those patients, their families, um, therefore increasing their intrinsic motivation to continue being an active participant within their healthcare and their plans. The nitty gritty of this comes down to reducing costs and improving patient outcomes. There were there is a group that conducted a literature forgive me a literature review where they analyzed four different case studies. Those four case studies were centered around new mothers, mental health communities, hospital based patient engagement programs, and genetic screening programs. And what this literature review found and concluded was that the more the programs played into the cultural sensitivities of the patients, the more they engaged. And although these four case studies represent a very small percentage of the nation's demographic and programs, it does show and support the idea that the more culturally sensitive we are, the more we can engage patients on a smaller scale. Now, if we multiply that to a larger scale nationally, we can only assume and anticipate that more patient interaction and engagement would improve our pre-existing programs, expand the reach of these pre-existing programs, and also allow us to develop programs that more closely identify and meet the needs of our patients. Secondly, there is a patient activation measure, which you see here, level 1, 2, 3, and 4. And there was an analysis done in a small patient population in Minnesota. And in this patient population, the patient activation measure was studied over a period of 2 years. And what this group found was that patients who went from a level 3 to a level 4 would then demonstrate a 9% decrease in overall costs. Within that same time period, patients who went from a level 4 to a level 3 would then therefore cost an additional 14% more if compared to if they would have remained within a level 4. This speaks to the importance of being culturally competent to be able to relate and make the patient feel autonomous and competent to be motivated to continue their care within our patients or within our hospitals and our systems to reduce costs in the long term, and to place that in a larger picture. Within that 2-year time frame, if patients who went from a level 4 to a level 3 would have remained within level 4, it would have saved that hospital $2.6 million. Now, one of the limitations of the study is that it was a small patient population in Minnesota, and that the patient population within this study also may not have reflected all of the patients of Minnesota accurately. However, this is base data and financial data that supports the idea that for healthcare providers who are culturally competent can engage the patients in a long-term aspect and model, can increase the efficiency of their medical treatment and also reduce the costs of healthcare. Thank you for listening, and I look forward to discussing with you all.